She came in on a Tuesday afternoon, a retired school teacher from Indiana, 69 years old, sharp as a tack, the kind of woman who still did the New York Times crossword in pen every single morning. Her name was Margaret. She had come in for what she described as a routine checkup, blood pressure, cholesterol, the usual. But before I could even pull up her chart, she pointed to the back of her neck and said, "Doctor, what are these little bumps? I've had them for about 3 years now. My last doctor said they were nothing." I looked. Small, soft, flesh-colored growths, 4 of them, clustered along the base of her neck. I checked her armpits, 3 more. I looked at her and I said, "Margaret, when did anyone last check your blood sugar?" She looked at me with complete confusion. "My blood sugar? I don't have diabetes. Nobody in my family has diabetes." Her fasting glucose that afternoon came back at 118. Her HbA1c was 6.1%. Margaret was pre-diabetic, had been for years, and the only thing her body had been doing, quietly, patiently, desperately, to get someone's attention, was growing those small bumps on her skin. 3 doctors over 3 years had looked at them and said nothing worth remembering. I am Dr. Pablo. I am a board-certified geriatrician with 18 years of clinical experience working with adults over 60, and I want to spend the next 20 minutes giving you the conversation that Margaret never got, the one that could change everything for you. Because here is the truth that gets buried somewhere between a rushed appointment and a waiting room full of patients. Skin tags are not random. They are not merely cosmetic. They are not simply what happens when skin rubs against skin for long enough. In a significant number of people, particularly adults over 60, skin tags are a visible external signal of a dangerous internal process that has been building for years. A process that, left unaddressed, leads to blindness, kidney failure, nerve destruction, heart attack, and stroke. And the reason this matters so urgently is that the window to reverse it, the window where real meaningful change is still possible, is open right now. While the tags are small, while the blood sugar is climbing but not yet catastrophic, right now is when this conversation needs to happen. The medical term for a skin tag is acrocordon. They are benign fibrovascular growths, meaning they contain both fibrous tissue and small blood vessels, and they hang from the skin surface by a thin stalk of tissue. On their own, they cause no pain, no infection, no direct harm, and that is precisely why they get dismissed. Because in medicine, if something is not actively hurting you in this moment, it tends to get pushed to the bottom of the priority list. But what the research has been telling us for over 2 decades is that these growths are metabolically significant. They are a window into your hormonal environment. And in adults over 60, that window reveals something that demands your full attention. A landmark investigation published in the Journal of the European Academy of Dermatology and Venereology examined over 100 patients presenting with multiple acrocordons and found that the prevalence of insulin resistance among that group was dramatically elevated compared to age-matched controls without skin tags. The researchers were not looking at sick patients. They were looking at people who considered themselves healthy, people exactly like Margaret. And what they found was that the skin was broadcasting a metabolic alarm that the rest of the medical system was not hearing. A separate analysis published in the Postgraduate Medical Journal found a statistically significant correlation between the number of skin tags a person carried and their fasting insulin levels, meaning the more tags, the higher the insulin, and the deeper the resistance had taken hold. Now I want you to understand why this connection exists, because once you understand the mechanism, you will never be able to unsee it, and that is exactly what I want. Your body runs on glucose. Every cell in your body, your heart muscle, your brain, your kidneys, requires a steady supply of glucose delivered through the bloodstream to function. The hormone responsible for that delivery is insulin, produced by the beta cells of your pancreas. Every time you eat and blood sugar rises, insulin is released. It binds to receptors on your cells, and glucose moves from the blood into the cell where it is burned for energy. In a young, metabolically healthy body, this system runs with extraordinary precision. But here is what happens across decades of modern American eating, and I say this not to assign blame, but because understanding the timeline is everything. Every meal high in refined carbohydrates, the white bread, the breakfast cereal, the pasta, the crackers, the sweetened yogurt, the orange juice, sends a surge of glucose into the bloodstream. Insulin rises sharply to manage it. This happens 3 times a day, every day, year after year. And gradually, in a process that is invisible and painless and completely asymptomatic, your cells begin to respond less efficiently to insulin's signal. They have heard it so many times, at such high volume, that they begin to tune it out. This is insulin resistance, and it is happening right now in an estimated 88 million American adults, the overwhelming majority of whom have no idea. Your pancreas, recognizing that the normal amount of insulin is no longer doing the job, compensates by producing more. Blood insulin levels rise. And it is this state of chronically elevated circulating insulin, called hyperinsulinemia, that directly drives skin tag formation. Insulin activates insulin-like growth factor 1 receptors embedded in your skin cells. Those receptors, when chronically stimulated, tell certain skin cells to proliferate abnormally. The result is a soft hanging growth on the surface of your skin. Your skin is not malfunctioning. Your skin is performing a function. It is giving you a map of what your pancreas has been doing for years. Now I want to walk you through exactly where on your body these growths appear. Because location is not incidental. Location is diagnostic. The areas where insulin-related skin tags form are not random patches of skin. They are specific microenvironments, warm, folded, high-friction zones where insulin receptor density is particularly concentrated, where skin presses against skin and creates the precise conditions that hyperinsulinemia exploits most aggressively. And I want you to do something while I walk through these locations. I want you to actually think about your own body, not abstractly, specifically, because one of the most powerful things you can do in the next 10 minutes is move from passive listener to active investigator of your own health. The first location is the back and sides of the neck. This is the most common site and the most frequently dismissed. The skin along the posterior and lateral neck is warm. It folds naturally with movement, and it has an exceptionally high concentration of insulin-responsive cells. What I see in my clinic, over and over again, is patients who have had 3, 4, 5 small soft growths along the neckline for years, often hidden beneath a shirt collar or a necklace, and who have simply never thought to mention them because nobody ever told them they were worth mentioning. If you reach back right now and feel along the base of your neck, both sides all the way around, and you find small soft bumps that were not there 10 years ago, I need you to hold that information in your mind as we continue. The second location is the axillary region, your armpits. Lift your arm and examine the skin carefully. Insulin-related tags here are frequently misattributed to razor irritation or clothing friction, and while friction does play a role in tag formation generally, friction alone does not explain clusters of multiple soft growths appearing bilaterally, meaning on both sides, in a person who has had no change in their shaving habits or clothing. When I see bilateral axillary tags in a patient over 60, I do not reach for a dermatology referral. I reach for a metabolic panel. The third location is beneath the breasts and within the abdominal skin folds, particularly relevant for women and for anyone carrying excess weight in the midsection. The warm, moist environment created by overlapping skin creates ideal conditions for insulin-driven proliferation, and the tags that form here are often larger and more numerous than those found elsewhere. I had a patient, a 71-year-old retired hospital administrator from Georgia named Dorothy, who came to see me about fatigue and what she described as just not feeling right for about 2 years. She had attributed everything to getting older. When I examined her, I found 11 skin tags distributed between her neck, both armpits, and beneath her abdominal fold. Her HbA1c was 6.8%. She was diabetic, had been by the biochemical evidence for at least 3 years. 11 visible signals on her skin, 2 years of fatigue, and not once had anyone connected the picture. The fourth location, and this is the one that consistently surprises my patients the most, is the eyelids. Small, soft, pedunculated growths on the upper or lower eyelid margin are strongly and repeatedly associated in the literature with both insulin resistance and dyslipidemia, meaning elevated cholesterol and triglycerides. A paper published in Diabetes Care found that patients with periorbital skin tags, tags around the eye area, had significantly higher rates of metabolic syndrome than those without. If you have noticed small, soft growths near your eyes that were not present in your 50s, please treat that as a priority signal and not a cosmetic inconvenience. The fifth location is the groin and inner thigh. I raise this not to alarm, but because it is a location that patients frequently discover on their own and then never mention to their physician out of embarrassment. I want to be direct with you. There is nothing embarrassing about your body communicating metabolic distress. Multiple soft tags along the inguinal fold, the inner thigh, or the groin area, particularly when present alongside tags in any of the other locations I have just described, constitute a pattern. And patterns in medicine tell stories that isolated findings cannot. Here is the question I want you to sit with right now. Not one location, not one tag, but multiple locations, multiple tags, appearing gradually over the last several years. If that description fits what you are finding on your own body, then what you are holding is not a cosmetic concern. What you are holding is years of your body's most honest communication about what has been happening inside your bloodstream. I want to pause here and ask you to do something for me. Write your age and where in the world you are watching from in the comments below. I read every single comment personally, and I want to know who is in this conversation with me today, because what I am about to share next is the part that most doctors simply do not have 20 minutes to explain, and you deserve every word of it. Now I need to talk about something that exists on a spectrum beyond skin tags, something that represents a deeper stage of the same underlying process, and something that a shocking number of seniors have on their bodies right now and have been told is nothing to worry about. It is called Acanthosis nigricans. It presents as a darkened, velvety, thickened area of skin, not a growth that protrudes, but a patch that darkens and thickens and takes on a texture that has been described by patients as feeling like velvet or like a permanent shadow on the skin. It appears in exactly the same locations as insulin-related skin tags, the back of the neck, the armpits, the groin, and it represents a more advanced degree of the same insulin-driven cellular overstimulation. What breaks my heart in clinical practice is how often I hear the same explanation from patients who have had acanthosis nigricans for years. They thought it was a bruise. They thought it was a stain from a necklace or a watch strap. They tried to wash it off. I want you to understand something with complete clarity. Acanthosis nigricans does not wash off. It is not dirt. It is not a bruise. It is your skin responding to years of insulin excess by thickening and darkening the cells in those high receptor density zones. When I see a patient with both skin tags and acanthosis nigricans in the same locations, I am not wondering whether they have insulin resistance. I am wondering how far it has progressed. A study published in the Archives of Dermatology found that acanthosis nigricans had a positive predictive value of over 90% for hyperinsulinemia in non-obese adults. 90%. That is not a soft association. That is a clinical near certainty. I think of a man I will call Frank, 66 years old, former construction foreman from Ohio, proud of the fact that he had not been to a doctor in 4 years because he felt fine. His wife made him come in after she noticed a dark patch spreading along the back of his neck. He had assumed it was sun damage or the collar of his work shirts. His fasting glucose that morning was 214. His HbA1c was 8.1%. Frank did not have approaching diabetes. Frank had had uncontrolled diabetes, by his body's evidence, for a minimum of 5 years. 5 years of his kidneys under assault. 5 years of his blood vessels accumulating damage. 5 years of his nerves slowly being starved of proper circulation. And the entire time, the back of his neck had been holding up a sign. Frank is doing better now. He is on medication, he has changed his diet, his last HbA1c came down to 6.9. But he will spend years undoing damage that did not have to accumulate. So let me now give you what Frank did not have. The practical knowledge to act before the damage accumulates. Because everything I have described so far, the insulin resistance, the hyperinsulinemia, the skin tags, the darkening patches, all of it exists on a timeline. And the most important thing I can tell you about that timeline is this. You are almost certainly not at the end of it. You are somewhere in the middle. And the middle is where intervention is not only possible, it is powerful. The first thing I want you to do, not next week, not at your next scheduled appointment, but this week, is request 2 specific blood tests. Write these down. The first is a fasting plasma glucose test. You arrive at the lab having eaten nothing for at least 8 hours. They draw a single vial of blood, and the result tells you what your blood sugar is doing in its resting baseline state. A result below 100 milligrams per deciliter is normal. Between 100 and 125 is pre-diabetes. Above 125 on two separate occasions is a diabetes diagnosis. The second test is an HbA1c, glycated hemoglobin, and this one is even more revealing because it does not capture a single moment in time the way a fasting glucose does. It captures a 3-month average of your blood sugar control by measuring how much glucose has attached itself to your red blood cells over their lifespan. Below 5.7% is normal. Between 5.7 and 6.4 is prediabetes. At or above 6.5% is diabetes. Both of these tests are covered by Medicare. Both can be ordered by your primary care physician. And if your doctor is dismissive when you ask for them, I want you to use these exact words. I would like a fasting glucose and an HbA1c ordered at my next lab draw because I have concerns about insulin resistance. You do not need to justify that request further. It is your body, and you have every right to that information. I also want to add a third test that rarely gets discussed in a standard checkup, but that I consider essential for any patient over 60 who presents with multiple skin tags. It is called a fasting insulin level. Not a blood sugar level, an insulin level. This test measures how much insulin your pancreas is currently producing in its resting state, and it catches insulin resistance at an earlier stage than glucose testing alone. Because here is the critical sequence. Insulin rises first. Blood sugar rises later. A person can have a completely normal fasting glucose of 92 and a normal HbA1c of 5.4 and still have a fasting insulin of 18 or 22 microunits per milliliter, which tells me their pancreas is working 3 times harder than it should be to maintain that normal blood sugar, and that the system is under enormous strain that will eventually break. Optimal fasting insulin sits below 8. If yours comes back above 12, the conversation about intervention needs to happen immediately, regardless of what your glucose says. Now let me talk about what that intervention actually looks like, because this is where I see the most confusion and the most unnecessary despair in my patients. People hear the words insulin resistance, and they immediately imagine a future of medications and restrictions and a body that has permanently failed them. I want to dismantle that picture entirely. Insulin resistance in its early and intermediate stages is one of the most responsive conditions in all of metabolic medicine. The human body, even at 65, even at 72, retains a remarkable capacity to restore insulin sensitivity when given the right inputs consistently over time. The research on this is not preliminary or tentative. It is deep, replicated, and unambiguous. The single most impactful dietary change you can make, and I have seen this transform lab values in patients within 3 weeks, is the elimination of liquid carbohydrates. Not reduction, elimination. Every beverage that contains sugar or rapidly digestible carbohydrate, regular soda, fruit juice of any variety, sweetened iced tea, sports drinks, flavored coffees, energy drinks, delivers a glucose load to your bloodstream with no accompanying fiber, no protein, no fat to slow its absorption. The result is an insulin spike of extraordinary sharpness that, repeated multiple times daily over years, is among the most potent drivers of insulin resistance known to nutritional science. A paper published in Diabetes Care followed over 90,000 women across 2 decades and found that those who consumed 1 or more sugar-sweetened beverages per day had an 83% higher risk of developing type 2 diabetes compared to those who consumed less than 1 per month. 83% from 1 drink per day. When my patients eliminate liquid sugar, completely, not gradually, their fasting glucose typically drops between 8 and 15 points within the first 2 weeks. Nothing else changes, just that one substitution. Water, sparkling water, black coffee, plain, unsweetened tea. That is the entire list of what replaces it. The second change is what I call meal architecture, specifically the deliberate sequencing of what you eat within each meal. A series of elegant studies conducted at Weill Cornell Medicine demonstrated that eating protein and non-starchy vegetables before consuming carbohydrates at the same meal reduced the post-meal glucose spike by up to 37% and the insulin response by up to 57% compared to eating the carbohydrates first, even though the total caloric content of the meal was identical. Identical food, different order, dramatically different metabolic outcome. The mechanism is well understood. Protein stimulates the release of gut hormones including GLP-1 that slow gastric emptying and blunt the rate at which glucose enters the bloodstream, while fiber from vegetables physically impedes carbohydrate absorption in the small intestine. So when you sit down to any meal, the sequence is protein first: eggs, fish, chicken, beef, Greek yogurt, cottage cheese, then vegetables, then whatever carbohydrate is on your plate. You are not eliminating anything. You are simply changing the order in which it enters your body. And that order, practiced at every meal, every day, begins to reshape your insulin response within weeks. The third change involves something so accessible and so consistently underestimated that I find myself almost frustrated by how rarely it gets prescribed. Walking after meals. Not a morning walk, not an evening stroll unrelated to eating. A deliberate 10-minute walk beginning within 30 minutes of finishing each meal. Research from the University of Otago, published in Diabetologia, found that post-meal walking reduced post-meal blood sugar elevations by 22% more effectively than a single continuous walk of equivalent total duration taken at a separate time of day. The physiology is direct. Skeletal muscle contraction during walking activates glucose transporter proteins called GLUT4 in muscle cell membranes through an insulin-independent pathway, meaning your muscles absorb glucose from the bloodstream without requiring insulin to facilitate the transfer. You are essentially creating a glucose disposal mechanism that bypasses the broken lock entirely. 10 minutes after breakfast, 10 minutes after lunch, 10 minutes after dinner. 30 minutes of walking total, distributed across the day, doing more metabolic work than a single 30-minute session at any other time. I had a patient, a 68-year-old retired postal worker from Michigan named Thomas, whose fasting glucose was 132 when he first came to see me. He made no other changes except adding post-meal walks and eliminating his 2 daily glasses of orange juice. 8 weeks later, his fasting glucose was 107. He came into my office genuinely astonished. I was not astonished. The biology is reliable. What is unreliable is whether people actually do it. There is a fourth intervention I want to add, one that does not appear in most videos on this topic, and that I consider critically underappreciated for adults over 60 specifically. It is sleep. Not sleep as a general wellness suggestion, but sleep as a direct metabolic intervention with quantifiable effects on insulin sensitivity. A study published in the Annals of Internal Medicine took healthy volunteers and restricted their sleep to 5.5 hours per night for just 2 weeks. At the end of those 2 weeks, the fat cells of the study participants showed a 30% reduction in their ability to respond to insulin, a degree of insulin resistance equivalent to what might be expected after gaining 20 to 30 pounds of body fat. 2 weeks of poor sleep, 30% reduction in insulin sensitivity, reversed entirely when normal sleep was restored. For my patients over 60 who are fighting insulin resistance with diet and exercise, but sleeping only 5 or 6 hours a night, they are running uphill against a metabolic headwind they do not even know exists. 7 to 8 hours of quality sleep is not a luxury. It is a biological requirement for insulin sensitivity, and no supplement and no diet will fully compensate for its absence. Speaking of supplements, I want to give you 3 that carry genuine evidence behind them, with the clear understanding that supplements support a foundation of behavioral change. They do not replace it. The first is berberine, a compound derived from several plants including barberry and golden seal, which activates an enzyme called AMPK, sometimes referred to as the metabolic master switch, in a manner that increases cellular glucose uptake and reduces hepatic glucose production. A meta-analysis published in the journal Metabolism reviewed 14 randomized controlled trials and found berberine reduced fasting blood glucose by an average of 19.83 milligrams per deciliter and HbA1c by 0.71%, results that in some of the individual trials were comparable to metformin. The typical dose studied is 500 milligrams taken with meals, 2 to 3 times daily. Discuss this with your physician before starting, particularly if you are already on glucose-lowering medication. The second supplement is magnesium, specifically in the glycinate or malate form for best absorption. A comprehensive meta-analysis in the journal Diabetic Medicine found that magnesium supplementation significantly improved fasting glucose and insulin sensitivity in people with magnesium deficiency, and the sobering reality is that an estimated 48% of Americans Do not consume adequate magnesium from diet alone, a figure that rises substantially in adults over 60 because aging reduces intestinal magnesium absorption efficiency. Magnesium is a cofactor in over 300 enzymatic reactions in the body, including multiple steps in the insulin signaling cascade. When it is deficient, those cascades run inefficiently. Restoring magnesium levels is not dramatic or exciting, but it is foundational in a way that more glamorous interventions are not. The third is something I want you to find specifically and not substitute. Ceylon cinnamon, not the cassia cinnamon that lines most grocery store spice aisles. Ceylon cinnamon contains active compounds including cinnamaldehyde and type A polymeric polyphenols that have been shown in multiple randomized trials to improve insulin receptor sensitivity and reduce fasting glucose. Cassia cinnamon contains significant levels of coumarin, a naturally occurring compound that in the quantities consumed through supplementation can stress the liver over time. Ceylon cinnamon does not carry this concern. Half a teaspoon daily, added to food or stirred into water, is the dose supported by the research literature. I want to close by coming back to Margaret, that retired school teacher from Indiana who came in for a routine checkup and left with a conversation that changed the trajectory of her health. She called my office 14 weeks after that first appointment. Her fasting glucose had dropped from 118 to 101. Her HbA1c had come down from 6.1 to 5.8. She had eliminated her morning orange juice. She walked every evening after dinner, and she had started eating her eggs before her toast. She told me that she felt better than she had in 3 years, more energy, sleeping through the night, less of the vague heaviness she had attributed to getting older. And then she said something I have been thinking about ever since. She said, "Dr. Pablo, I walked past a mirror last week and looked at the back of my neck. I think one of those bumps might be getting smaller." Whether that is true or wishful thinking, I cannot say with certainty. I am Dr. Pablo. I will see you in the next video.